Hey guys, I am here with a special guest today, my BFF, aka husband. He's joining us for talking about the urinary system today because he has a great story that he's going to share later on. And then he's also kind of be in your place as the student. So he's going to work through all of the stuff that I'm going to be talking about today during this lecture. And if at any point in time he's like, I have no idea what the heck you're talking about, he's going to stop me so that way I can make sure that it's clear for all of you. So if I have things that I think maybe are very common and easy to understand and he's like, no way, that's really, really difficult to understand, he's here basically to help you. Now, keep in mind that while we're recording this, I cannot see his face at all because we can't see our face on the screen. So if he starts falling asleep or starts rolling his eyes in boredom or doing anything weird behind my head, I can't see that. So I hope you enjoy because he is a goofball and he's probably going to do some stupid stuff like that. So just be prepared for that.
Can I introduce myself before all this name calling starts? Dang. I'm nobody. I'm just her husband. That's it. The goofball. People call me Trey in the real world. She calls me baby. The kids call me daddy. Things like that. But my name is Tremaine. That's Mr. Jones to you guys. I'm going to be a professor one day. Nope.
All right, let's start. You're going to control the mouse. Or you want me to control the mouse?
Yes. I'm the guest, unless you're trying to put me to work.
All right. So in talking about the urinary system, we're going to be talking about the kidneys, obviously in the low back area. The ureters are going to be the tubes that connect the kidneys to the bladders. One bladder. Everybody has one bladder, two ureters. The urinary bladder, which we've kind of briefly looked at on some of the models in the past as we went through the reproductive system for male and female, but we'll just kind of refresh that. And then the urethra, we definitely looked at that on the male model because we talked about the different portions of the urethra, so we'll recap that as well. As we're going through this, please keep in mind what you see in red there. Kidneys remove metabolic waste from circulation and produce urine. A lot of times the reason why students have a hard time understanding what's happening in the urinary system is because they forget that really this is all about filtering blood. So this is really about making sure that the body is constantly checking what's inside of the blood. Do we need this? Do we have enough of this? What should we get rid of? All of those things are constantly going to occur within the kidneys so that the blood always stays exactly where it's supposed to be. If you're in my lecture class, you've heard me say 1,000 times, blood is bougie. So remember, blood is very specific on what it wants, and the kidneys are there to make sure that we can maintain that bougie blood. So it's going to do that by keeping good water balance, making sure that we have good electrolyte levels, and then making sure that our pH level is where it's supposed to be as well. Remember, when we talked about blood, there's a very particular pH level. If you do not remember that, go back and look at that again. So that way you know exactly where your pH level of your blood is supposed to be. The kidneys are really going to help to do that. And when we say the word micturition, that's just a fancy word for urination. I felt his neck go backwards. So micturition just means peeing. So whenever you urinate, this is the process of getting the urine basically out of your body. It's not going to stay in your bladder forever. The bladder is just a temporary holding vessel. We eventually got to get this out of the system. So that is the process of getting it out of the urethra, out of the body. On the picture there, you'll see below the urethra label, it says 4 versus 20 centimeters, 4 centimeters in the female, 20 centimeters in the male. So 4 centimeters for me, 20 centimeters for him, for this guy. Maybe a little bit more for you, babe. I don't know, just saying.
Can you say that big word one more time?
Which word? Micturition.
Micpictu.
Not a micpictu. Micturition.
So is your name Blood?
What?
You said the blood is bougie. I'm trying to figure out if you got a nickname. Okay, never mind. Keep going.
Okay, moving on. All right. Typical adult kidney is about 10 centimeters long, 5.5 centimeters wide, 3 centimeters thick, and it weighs about 150 grams. Look at the picture and you will see that the kidneys are going to be between around T11, T12, and then L3. The left side is going to be a little bit higher than the right side, and that's because on the right side you have your liver, so it pushes that right kidney down just a little bit. So left side is higher, right side is lower. If you're ever going to do the kidney punch test, basically what you're going to do is you're going to put your hand on the back of a person. You're going to feel for where that 11th and 12th rib is at. You're going to palpate for that rib so that way you know you're in the area of the kidney, and then you're going to basically take your fist and hit the back of your hand. If you do that to a person, that should not hurt them. So that punch, the kidneys are going to be protected by an area of fat, and it should not bother anybody who is not ill. But if somebody does have a kidney infection or their stones or something of the sort, they will get a very painful response from that, and that's a very easy, inexpensive way to kind of figure out if that person does have a kidney issue. So keep in mind where your left and your right sides are for the purposes of palpation for that. The hilum is the area on the medial aspect of the kidney. So you can see on the picture on the two sides of the spine, remember that's going to be medial. Anything further away from the midline, that's lateral. So on the medial aspect of the kidney, you have a little divot where it kind of comes in. This is the area where you're going to be able to have your artery and nerves and veins flow in and out of the kidney. The renal nerves are going to innervate the kidneys and the ureters. They're going to follow branches of the renal arteries that we're going to talk about in a minute to the individual nephrons. So we'll be going through where the nephrons are at, what the nephrons do, because those are the important functional units of the kidneys themselves. I forgot we had a mouse. All right, so this picture just shows you can actually see a transverse section. So find the spleen, move medially, and then you will be able to see the left kidney. Remember, spleen is on the left side. The kidney is sitting behind that pancreas. Remember, we refer to the kidney as retroperitoneal. Retroperitoneal meaning behind the peritoneum. So you can see that it's got a couple of different layers that is going to protect it, as I said earlier, including that fat pad, but it's also protected by muscles and bones in the area as well.
Hey, when you get a chance, you need to tell them about your Long John Silver's being pregnant pancreas story. You should tell them that.
Okay, that's digestive system, and it was Whataburger. So
was it Whataburger?
Yes.
Either way.
Either way. Okay.
Fat people problems.
So when we're looking at the inside of the kidney, we're going to open it up here in just a second. Well, we're not. But we're going to look at some pictures here, and what you will see on the outer aspect is the cortex. So remember, anytime we hear the word cortex, that's going to be on the outside. Medulla is going to be in the middle. So there's going to be an outer cortex and an inner medulla. Inside of that medulla, there are going to be structures that are called pyramids. So anywhere from 6 to about 18 pyramids are going to be within the medulla of the kidney, and those pyramids are going to basically converge or come to a little tip into a structure that's called papillae. And we'll look at that in just a second. Then those papillae are actually going to lead into a little area that's called a minor calyx. Minor calyxes lead into major calyxes, which then lead into the renal pelvis. These are step-by-step places where the urine can go as it leaves through the different parts of the kidney in order to get out of the kidney. So I'm going to walk through all of that whenever we get to the picture. Just make sure all of the words that are in red you're able to identify on the next few slides, and then on things like models. A quarter, can you believe this? A quarter. Total blood flow of body is delivered to the kidneys every single minute. Every minute. So that means in 4 minutes, your entire blood supply has gone through your kidneys. Depending upon what book you read. Some people say 20 to 25%. So it's either going to be 4 minutes or it's going to be 5 minutes for every single piece of blood inside of your body to go through your kidneys.
I'm pretty sure it's a little less than that for me. My blood's not that bougie.
It's the same for everybody, even if you're not bougie. Okay, yes I am. We know you are not.
This is like an eighth.
Alright, so here is our picture. I have put little squares around all of those structures that are in red from the previous slide. So these are the different structures you'll want to make sure that you do pay attention to as you're trying to label your models. On the little thing below, you can see there that you have the vessels that the blood is going to run through in your kidney. It's very, very, very important to make sure that you understand the flow of blood through the kidney, because remember, the whole purpose of it going there is for it to be checked and to be cleaned. So
blood is bougie. Blood is, oh my bad. Go ahead.
We're going to make sure that you can understand the flow, and it's really easy. If you watch some of your landmarks, it's very easy to do. I'll kind of help you with that. If you look at the green circle is an important part. So if you're taking notes right now, what I want you to do is put a little note next to the green circle and make sure that you write, pay attention to the flow through the nephron. Okay? So when we get into the nephron, that's going to be the small part. We're going there. We're not there yet.
Am I supposed to know what a nephron is?
Not yet.
Okay.
I'm going to teach you and everybody else.
Okay, because I was like, I don't see that. I ain't seen that yet. But okay. I'm with you.
Nephron is coming.
You're a great teacher.
So, we're going to look at this slide right here. In order to get through the kidney, we first go through the renal artery. That makes sense, right?
Yeah.
Renal means kidney. So, coming off of the abdominal aorta, we've got the renal artery. The renal artery is going to segment out across this kidney, so we call it the segmental artery.
Right.
Good?
Right.
Okay. So, as we segment out, basically what we're going to do is we're now going to go in between each of the lobes. A lobe is the pyramid plus the two columns on the side of the pyramid. So the pyramids are in pink.
Mm-hmm.
Okay?
Mm-hmm.
Two columns of tissue are going to be surrounding the pyramids. So if we go in between something, that's called this is a lobe, so we're going to call it the interlobar artery. We're going in between two pink structures. Good?
We good.
Okay. Then we're going to arch across the top of the pyramid. As we arch across the top of the pyramid, we're going to call that arcuate. It's an arch.
I see what you did there.
Okay. Good. I'm glad you're seeing it. As we arch across the top, the next step is to project into the cortex. So if you radiate somewhere, that means that it goes somewhere else. The cortex is where we're going, so we're going to go into the cortical radiate arteries. Okay? From the cortical radiate arteries, now we've got to blow up this pyramid. So what you can see is we have this pink pyramid that we're going to blow up. So we're going to start again from cortical radiate arteries. The next step is to go into the afferent arterioles.
All right, I'm going to head out.
Okay, so afferent arterioles are going to come off of the cortical radiate artery. I'm going to show you another picture here in just a second, but remember that nephron word that you were like, what am I supposed to know about that? Remember I told you.
Is it dead already? It's purple.
It's not dead. Okay. It's a tube, so it's going to be a different color structure.
Gotcha.
Okay, so let's go back really quickly. If we go backwards, there's our green circle again. Okay. So there's that first structure that confuses everybody. That's that afferent arteriole.
Still with the little fingers on it. Got it.
Okay, so that afferent arteriole feeds into the glomerulus. The glomerulus is the little red ball. So you can kind of see all of the little red balls that are hanging out at the end of the afferent arteriole. Don't.
What? I didn't say nothing. Jeez.
All right. So the afferent arteriole feeds the glomerulus. The glomerulus is the very first part of the nephron.
Okay.
It's very important that we understand what the glomerulus does, because if we do not understand what the glomerulus does, we'll be lost on everything. It feeds the nephrons. It does. It brings blood into the nephrons. That's
brings blood, feeds the nephrons.
Very good.
Check. Got it.
Got it. Okay. So, if we're looking at a model,
it brings blood, it feeds nephrons.
Yep.
Got it.
If we're looking at a model, it's going to look a little funky.
The balls is hanging out. It's not funky. I'm used to this.
So what we've got here is you can see that cortical radiate artery coming up off of the arcuate artery. That afferent arteriole is feeding into that glomerulus. Okay?
Balls hanging out.
Balls hanging out.
Feeding. Got it.
Got it? Okay.
Nephrons.
Nephrons. All right. So the nephron, this is what you have to know, is the functional unit of the kidney. The nephron is where all of the important stuff is going to occur. So the nephron is this tiny little bitty microscopic structure where all of the process of the blood is going to be cleaned. Okay?
So it's safe to say, and I'm just guessing because I'm not a doctor, when people are on dialysis, this structure is jacked up.
Boom. Yes.
I get an A in the class.
Yeah, you do. All right. So,
I quit.
Okay, so whenever your nephrons do not work, you are not able to cleanse your blood. So yes, that is why you would need dialysis, because your nephrons have been destroyed. There's a couple of different reasons why that can happen. That's something more of a lecture side, so we're not going to get into that much on this lab component. But there is definitely lots of things that can go wrong if that nephron is not working like it's supposed to. So it's very, very important to make sure that you do nourish your kidneys. Make sure that you keep eating good, healthy foods so that you don't damage these nephrons.
And drink lots of water.
And drink lots of water. That's perfect.
Beer doesn't count.
Beer does not count.
I got banned from beer, I'm just saying.
Beer damages the nephrons.
Pray for me, guys. Pray for me.
Okay, they will. All right. So I put at the bottom there a little YouTube link as we walk through this. If you need to go back and you need to look at this YouTube video to kind of help yourself with what are the different things that occur inside of the nephron, then feel free to look through that video if you like that. That way you can kind of see things drawn out. I am going to draw here in just a little bit, hopefully. Maybe I should have you draw, but
oh no.
We'll see how that goes.
She's trying to put me to work.
All right, so here we go. We're going to talk about the nephron because this is the functional unit that is going to help us with the blood cleansing. Now, what you can see on this slide right here is that the nephron is divided into two major pieces. So fix your eyes upon the first circle around renal corpuscle and then the second circle around the renal tubule. The renal corpuscle, as you can see, is the first part of the nephron, and it includes, there's that G word. What's the G word? What is it? It's not the little ball anymore. What do we call it?
I can't read. I'm out.
Glomerulus.
I told you I quit a while ago. I got it right the first time and I'm out.
Okay, so the glomerulus, now you can see again inside of this renal corpuscle. The glomerulus is that thing that we just said was fed by the afferent arteriole.
I like little red balls hanging out. It's a lot easier to remember.
It's a lot easier for you?
Yeah.
Okay. All right. The afferent arteriole.
So if you put that on the test, if I'm standing around and y'all put that on the test, I'm going to make you give you at least a half a credit.
Has to be glomerulus if that's what the question is asking, okay?
I tried.
So as we look at this renal corpuscle.
Glomerulus.
Inside is the glomerulus, fed by the
it starts with A.
Afferent.
Afferent.
Arteriole.
Arteriole.
Okay.
My
So
bad.
the afferent arteriole feeds blood into the glomerulus. Now, does everybody see the little...
It's right there on the screen.
Yes, it's on the screen if you would just look at the screen. Everybody should see the little green arrow. So we'll talk about what that green arrow is representing here in just a second. But before we do that, right above the afferent arteriole, what is that? What is that on the screen?
Efferent.
Efferent, or efferent, depending upon where you're from.
I'm from East Texas. It's efferent to where are we from?
Okay, so we're going to say efferent so that you know what I'm saying.
Bougie people.
So the efferent arteriole is going to come out of the glomerulus. It's what's going to exit. Blood has the ability to come in via the afferent and exit via the efferent. So whenever blood is coming into this glomerulus, some of it is going to exit the efferent arteriole, about 80% of it. Question is, where does the other 20% go?
To the trash can, to the pee-pee.
Okay, so the other 20% follows the green arrow. And what it's going to do is it's going to come out of the glomerulus and get into this capsular space that surrounds the glomerulus. Okay?
Because it's got to feed it.
We're already done feeding.
My bad. I like to eat.
I know. So the blood comes in through the
Glomerulus. No, the afferent arterial.
Yep. And it feeds the big ball. What do you call the big ball?
The glomerulus.
Glomerulus. How does blood get out of the glomerulus?
The efferent.
Efferent arterial. Very good. How much percent?
80.
And the other 20% is going to go into the
tubular structure.
Well, not yet.
Oh, dang.
Don't skip steps.
Okay, it surrounds the glomerulus.
Yes, into the capsular space.
Capsular space.
Into the capsular space.
Whew.
So.
Is it break time yet?
No. Okay. So capsular space is basically going to be in the area around the glomerulus. Think about this as a cap. It's good that you wore a cap today, baby. So glomerulus, capsular. Glomerulus. This is the cap. Whew. This is sometimes referred to as Bowman's capsule. So it could also be called the glomerular capsule. In between his head and this hat, there is a space. That is the capsular space.
Full of air.
Full of air. So this is Bowman's capsule. His head is going to be the glomerulus. And in between the cap and the glomerulus, there is a space there. All of the blood that moves into the capsular space does so because of one word that you have to remember, and that word is pressure. Okay?
Pressure,
yes.
Pressure.
So, blood comes in through the afferent arterial, into the glomerulus. 80% of the blood leaves the glomerulus through the efferent arterial. And then the other 20% goes into the capsular space.
Oh, capsular space.
Correct. Okay.
That's
so
how I see it.
How does it get there? How does it get into the capsular space?
Pressure.
Very good. So pressure is going to force this fluid out of the glomerulus because it's basically a capillary bed. The blood pressure forces fluid out of that capillary bed in order to get into the capsular space. Once it's in that capsular space, it is now called filtrate. All right? Filtrate. It's been filtered.
Right. That's what I was just going to say. That's what the kidney's for. We filtrate the blood. I got it. We
so
good.
Now we have our filtrate. Anything that has left the efferent arterial is going to go through a system of capillary beds called peritubular capillaries. We're going to talk about that in a minute.
Sounds soft and squishy. Can we get say it again?
Peritubular capillary.
Can I get a peritubular mattress?
Sure. So all of the blood that comes out of the efferent will end up in the peritubular capillaries. Anything else that's filtrate is going to go out of the capsular space and into the tube. That's where the second portion of the nephron comes in. So we're now in the renal tubule. The first step in the renal tubule is called the proximal convoluted tubule. It's convoluted, looks all crazy. You can see how twisted and contorted it is. Proximal because that is the one that is closest to the glomerulus. Okay?
Got it.
Okay. After the proximal convoluted tubule, then we're going to dip down. You can see that loop there. It's called the nephron loop, aka the loop of Henle. It's going to come back up, and then that leads to the distal convoluted tubule.
I will force her to give free grades for a nephron loop dance and a pressure jingle. I got it.
It's a good idea, baby.
Send it to me. Send it to her. Don't send it to me. Send it to her. Jingles, dances, nephron loop. Let's see it.
All right. Sounds good. So, all in all, whenever we're looking at the nephron, we have two major subdivisions. We have the corpuscle and we have the tubule. Altogether, the corpuscle and the tubule are going to work on filtration, reabsorption, and secretion. The filtration, the reabsorption, and the secretion are the three steps that it takes in order for us to cleanse our blood and get urine. You got to go through those three.
I gotta go pee.
Oh, do you?
No.
Okay. Every single kidney has somewhere between 1 million and 1.25 million nephrons. Can you even imagine that? Like that many of those structures inside of one kidney? 1 to 1.25 million.
That's crazy.
Yeah, it is crazy. Okay? So, they're super important. You can see on this particular...
So do they all like die at one time? Like when people need dialysis, like everybody just quit at one time?
No, they don't all quit at one time. They eventually just it's like a progression of things.
Oh, okay.
Okay?
Anyway, I got you.
All right, so you can see that there's different cell types within different parts of the nephron, and all of that has to do with structure and function. Different parts of the nephron are going to be responsible for different functions, so therefore there will be different structures. Remember, we talk about that all the time. Anatomy is structure, physiology is function. The two always go hand in hand. So that's why there's all different types of cell types there. Whenever we look at the two different types of nephrons, we have a cortical nephron and we have a juxtamedullary nephron. About 85% of our nephrons are going to be cortical, which means they're mostly going to be within the cortex. The juxtamedullary, the other 15%, is going to be at the junction between that outer cortex and that inner medulla. So the juxtamedullary nephrons are going to have the same structures as the cortical nephrons. They still have the glomerulus, still have the PCT, still have the loop, still have the DCT. All of it's the same. Are you okay?
Really. It's okay though.
But the difference is the juxtamedullary nephrons, their loop actually dips a whole lot deeper into the medulla, which makes a different concentration gradient. And it allows us to properly absorb water.
Whoa. What is concentration? What?
Okay, so.
Say it again.
So, concentration gradient
is for?
If you have concentrated urine.
That's when it's real yellow?
Real yellow.
That means I drank too much beer.
Okay, that's diluted urine.
Oh.
So, concentrated urine, you're dehydrated. You haven't had enough water.
I can't afford that, so that's out. So
yeah.
I ain't never got that.
Can't do that. So, the concentration gradient is going to be different in the juxtamedullary nephrons because they dip deeper into the medulla. So, in lecture, we'll talk more about how that concentration gradient is actually achieved based upon the movement of water and sodium and chloride. Right now we're not going to get that deep into it, so just know that the cortical nephrons, the juxtamedullary nephrons, they have all of the same structures. There's just a difference in how deep that loop of Henle actually goes into the medulla, which can change the concentration gradient of the juxtamedullary nephrons. Whenever we're looking at the collecting ducts that you also see there in the picture, multiple nephrons will share the same collecting duct. So once everything goes through the filtration, the reabsorption, and the secretion, it gets dropped off into the collecting duct, which is that long structure that you see there. But multiple nephrons will share collecting ducts. We'll talk about those more in a minute as well. Between the things that dip into the medulla, this is the reason why the pyramids have the striped appearance. It's why they don't look just plain. It's these structures that are actually creating that stripy appearance. I guess stripy is not really a word, but you get it.
Stripy.
Stripy. Okay. So here's a picture. On the left-hand side, what you will see are the cortical nephrons.
Of a yarn ball that got thrown down the street and rolled back up.
Basically, that is what it looks like. That's a pretty good analogy, babe. On the left side, remember we talked about the peritubular capillaries?
Right.
Okay. So remember, how does blood get into the glomerulus?
The
afferent.
Afferent, my bad.
Good. It goes into the glomerulus, and how does it get out?
The efferent.
The efferent. So from the efferent, if you follow the picture up here, find your efferent arteriole, ultimately this is going to lead into that peritubular capillary bed. So the peritubular capillary bed just completely wraps itself around that nephron. So the PCT, the loop, the DCT, all of it kind of just
makes a mess.
Makes a mess. does
Got a
make
mess inside your kidneys.
Okay. The other thing.
So don't go messing it up not drinking water.
Exactly. The other thing that is different with the juxtamedullary and the cortical.
Can you hand me water? I'm thirsty.
Yes.
It's right there. Looking around, didn't want to share. Bougie, didn't want to share her water with me.
The other thing that's different is the juxtamedullary nephron has what's called the vasa recta. So the vasa recta is a peritubular capillary bed that goes in a parallel to the loop. So can you see how this is around the loop and it's parallel to the loop?
It's got that drip. I see it.
Yep, it actually kind of does.
It drips so hard. Oh, I ain't gonna sing that song right now.
All right, so that vasa recta is in a parallel formation, which means it's basically going to slow the blood down a little bit and help us to get that gradient that we were looking for earlier, that good concentration gradient as well, okay? But it also comes up from the efferent arterial, so it's very similar type structure.
Pressure. Don't forget pressure.
Right, because the blood came out of the glomerulus.
The blood came streaming down. Anyway,
from
know about that
pressure.
part.
From pressure, right. Okay. And now, whenever we look at the model, again, this is the same model as earlier. Now you can just see the peritubular capillary bed
red balls is back.
up into the cortex, and then the vasa recta is going to be down in the medulla, since the vasa recta is associated with juxtamedullary nephrons, and that is going to be in the medulla.
Right.
All right.
Pop quiz.
So, two major parts to the nephron. The renal corpuscle, which is the area for the filtration.
Right.
Okay? Renal corpuscle is in the cortex.
Right.
Renal tubule is where we do
The medulla.
filtrate processing.
Oh, my bad.
We're going to, yeah, it can be in the medulla, in the juxtamedullary nephron.
Right.
Yeah.
Big loop.
Yeah. And even in the cortical nephron, some of them do dip down into the medulla a little bit. So the renal tubule is where we're going to process all of that filtrate, that 20% that went through because of pressure. So the tubule is where we're going to process all of that into urine via reabsorption and secretion.
Yeah.
Those are the two things that we're going to use. So those are the two fill in the blanks, reabsorption and secretion.
We're going to soak it up, spit it out. Got it.
All right. So let's talk about this renal corpuscle. Remember, that's one part to the nephron. The second part was the renal tubule.
Oh, you got words missing.
Because it's fill in the blank.
Oh.
So, right there on number 2, write in renal. After renal, write in tubule. The renal corpuscle is the glomerulus plus Bowman's capsule. So, glomerulus, Bowman's capsule. What's in between the two?
Just a little blood.
Some space.
Okay.
Where the blood can go. Exactly. So this is just a recap. The glomerulus is fed by the afferent arteriole. It's either called the glomerular capsule or the Bowman's capsule. It's just an AKA. You can use whatever word you want. There's a visceral layer with podocytes that interdigitate with each other and cling to the endothelial cells. Okay, so
we gonna enter what?
At this point, here's what you got to do.
At this point, I quit. I'm out.
On that glomerulus, remember it's that ball of capillaries.
Right.
Right? Okay, so now you take your hands and you do this. So you guys have to do this as well. So take your hands. Baby, take your hands and do this.
I'm not in this class.
Okay.
I'm not a gang member.
So, see how we are keeping some space in between our fingers. So we're not like this. We're
now.
like this.
Okay, I got fat fingers. Mine don't look like yours.
Okay, it's okay. It doesn't matter if your fingers are fat or not. So, there's spaces. So, space.
Oh, geez.
Space. Space. So
Please
there's
don't
spaces.
Cut me with them knives.
The spaces are very important. Thank you for showing us the spaces. The spaces
It's a movie, don't worry about it.
are little slits that are formed by these podocytes. So the podocyte slits are what are going to be the areas where that blood that is coming against the pressure, that's how it actually gets out of the glomerulus, is through the slits.
Somebody's thinking about a pressure jingle right now.
Okay, that's fine. So you have the slits that are created by the podocytes. So make sure you keep that in mind. If we look at a model, what you can see here, this is the glomerulus.
It's a cut open octopus.
The glomerulus is inside here. So this is it. Now you can see the podocyte cell on top of it, and they interdigitate like this. So the interdigitate is because they have these foot processes called pedicles. And so their pedicles kind of do like this, creating those slits, and because of the pressure, fluid is forced out of the glomerulus.
I think we should do this together.
That'd be great. Oh, I love that idea.
No pressure. No pressure.
Pressure.
Weirdo.
Okay,
Always doing.
This is a high pressure capillary bed. You have to remember that. This is a high pressure capillary bed. There's two arterioles. Remember, the afferent feeds it. Any blood that does not get filtered through is going to leave through the efferent. So your labeling on this particular slide, the red one is the afferent, the red label. The yellow label is the efferent. Okay? The afferent is much bigger. Because the afferent is much bigger, that means that a whole lot of blood can get in faster, and because the efferent is smaller, that means that the pressure can build inside of the glomerulus and push the fluid through the slits.
All right.
Does that make sense?
I was trying to figure out what the green thing was, but that's just laying on the model.
That's just laying on the model.
Okay.
Yeah, don't get distracted.
ADD.
Okay. So, because this is a high pressure system, because of the size of the arterioles, because of the podocyte slits, basically what we've got now is we've got this filtrate that comes out. That's the 20% that comes out.
So the afferent is like a fire truck water hose, and the efferent is like your yard water hose.
Very good, yeah.
Gotcha.
Yeah, that's right.
Check, I'm ready. I gotta make it make sense to me.
Okay, make it make sense. That's why I have you here. So,
Jesus Christ.
when we form the filtrate, this looks very similar to the blood plasma, except it's not going to have things like proteins in it because the proteins are too big to get out of the slits. So whatever comes out in the filtrate is whatever's small enough to fit through the slits. It has to be small.
Right.
Okay.
Because I want to keep my protein because I'm gonna absorb that in a minute.
Yeah, you want to keep your
Fat
protein
boy,
because
hungry.
if you lose your protein in your nephrons, it's going to be a bad day.
Oh, trust me, I know. I've been there,
Yeah.
done that.
So
We'll talk about that later.
we'll talk about that later. So in our filtrate, we have things like water, glucose, ions. Anything that's small enough to get out of those slits is actually going to come out in the filtrate. So all the things that you see down in red there are some of the things that you may see inside of the filtrate. This is looking at the actual glomerulus underneath the microscope. So if you were to look at the microscope slide, you can see there the capsule. It's encircling the glomerulus, and in between the two you have the little space. Okay?
Looks like a little baby brain.
Here's another slide for the glomerulus. Also, what we have to talk about at this point is, in addition to having the slits there, we've got some other things in this area that are very important to point out. The juxtaglomerular apparatus, or the juxtaglomerular complex. This is an area within each little nephron that's going to play a very important role in regulating blood pressure and the formation of that filtrate. And these things are going to ensure a good constant flow through the glomerulus so that we're constantly cleaning out that blood. You can see that I have circled the juxtaglomerular complex down here on the left-hand side.
So all this is the JGA, all of it?
Just these three things here that are in the circle.
Oh, okay.
The three things in the circle are a part of the JGA.
Okay.
So you have the macula densa, the extraglomerular, and the juxtaglomerular cells.
Right.
If we look on the next slide, this is one of the models that we have in the lab that will show you representations of some of the JGA. So if you're looking at this particular thing, again, orient yourself. All of the orange is the glomerulus. You have the afferent.
Efferent, that's the small one.
The afferent is the big one. The efferent is the small one.
Oh, I see what you did there. Tricked me on the mouse thing. Got me.
Now the reverse.
Trying to make me fail the test.
You see how model makers do you?
Man, look.
So you got to be careful with that. You got to pay attention to size. On the macula densa cells, These are actually epithelial cells of the distal convoluted tubule, and they are going to function as either chemoreceptors or baroreceptors. So chemoreceptors, remember, they're going to sense things like oxygen levels, CO2 levels, pH levels, and then the baroreceptors are going to sense pressure. So is the pressure too high? Is the pressure too low? The juxtaglomerular cells also have baroreceptors, and they can sense if the pressure is too high or if it's too low. But the juxtaglomerular cells are going to be in the walls of the afferent arteriole. And if the pressure gets too low, then they have the ability to secrete renin, which is an enzyme that we'll be discussing more in lecture. But essentially, renin is going to be released in response to low blood pressure. Because think about it, if you have low blood pressure, then you're not going to be able to have enough pressure to force out of the glomerular bed and make it into filtrate. So then you're not going to be cleaning your blood like you're supposed to. That's not going to be a good thing.
It's called bad blood right there. That's what we say in the hood. Got bad blood.
So the baroreceptors will help you ensure that if the blood pressure is too low, that renin can be secreted, so that way we can maintain this good glomerular filtration rate. Again, talk about that more in lecture. There's also hormones that will do the opposite. So if blood pressure becomes too high and the baroreceptors are saying, hey, this is too much, then there are hormones that can help lower that blood pressure as well. Extraglomerular cells are going to be located between the afferent and the efferent, and they're going to just provide feedback control, because we can also change the diameter of the afferent and the efferent if we need to in order to help adjust, because we always want to maintain.
We can't change it. The body does it.
The body does it. That's right.
Ain't got no switches on me like, yeah, turn that down, turn that down.
Yeah, exactly. Homeostasis. All right?
Ain't nothing balanced.
So, now we've gone through the glomerulus.
Whew.
What did the glomerulus do?
I don't even remember. Filtrate blood, I guess.
Yes, it filters the blood. That's good. Comes in through the afferent.
Leaves through the E.
80% leaves through the efferent.
The rest of it hangs out in the capsule.
The 20% hangs out in the capsular space. That's good, babe. Once it gets in the capsular space, that's when we call it the filtrate.
And you got to do the pressure.
All because of pressure, and it fits through the
spaces,
the slits and the podocytes. Exactly. Okay? So that's all of the things that are going to happen in the renal corpuscle.
I really know more about pee than I want to right now.
Okay. Well, I had to learn all of this whenever it came to helping you. So, years later, it's okay. That being said, that's all of the steps for the renal corpuscle in, big picture. Whenever we look at the renal tubule, the second portion, where we get into the PCT, the loop, the DCT, the collecting system, all of that is going to be what we talk about now. So, all of the stuff that comes into the capsular space, we call it filtrate. Once it leaves the capsular space and gets into the PCT, we call it tubular fluid. Okay? Because it's now fluid inside of the tube.
Why does it sound like I'm birthing a baby?
Okay, I don't know, but tubular fluid. It's fluid inside of the tube.
Okay, sure.
Okay. All right.
How you gonna go from blood to being just fluid? How that work?
Because remember, it's filtered. It's not truly blood because there's no proteins. The plasma concentration is different from blood than it is from tubular fluid.
I'm sorry, I did not mean to piss you off.
Okay, you didn't.
See what I did there? Come on.
If you don't understand what I'm teaching you, then don't be all pissy about it. Okay.
I see what you did there. Right now, I feel like I gotta go.
Okay, so that being said, we go from blood plasma inside of the glomerular capillaries to filtrate inside of the capsular space
into the
to
PCT.
Tubular fluid once we get inside of the PCT.
Got
okay?
it.
So this tubular fluid is going to be messed with. 99% of it is actually going to go back into the circulatory system. 99%. We're going to mess with it that much. I'm going to walk you through that.
Because you just said it wasn't blood no more, so what, you just going to put water back in there? Last time I checked, you cannot replace blood with water.
Okay, but majority of plasma is water. 90% of plasma is water.
Y'all knew that?
They should have known that because we already learned that.
Okay, just checking.
Okay, so 99% of that filtrate is going to be reabsorbed. Here's where things get a little bit confusing. So here's where you got to follow me for sure. Like if you're texting or you're trying to eat something right now, stop what you're doing. A lot of students get confused on the reabsorption and the secretion because there's a lot of stuff happening all at the same time. So if we look here at
start at suck it up. That's absorption. Start there.
Okay, we're going to start at reabsorption. Whenever you look at the arrows that are going away from the tube, you see all these arrows going away from the tube?
Yeah.
Okay. That is going to be signifying that there is reabsorption happening there.
Okay.
It's leaving the tube and going back into the circulatory system. You remember that ball of yarn that was wrapped around?
Yeah.
That peritubular capillary bed is where it's going to go. So It's going to go back into the blood supply.
I can live with that.
Okay? So that's reabsorption. We're taking it back. It's kind of like we were watching The Voice the other day.
This is the voice.
Yeah, exactly. As we were watching The Voice, you see that some of the coaches, they lost the people that they wanted on their team.
Still.
Yes.
Come on home.
And they said, come on back. Like, I need you back. So the process of reabsorption is, I actually needed that. I didn't want to lose that, and it would best benefit me to get it back.
You know I'm going to say my bad.
My bad.
More like Indian giving.
Okay.
Give it back.
Give it back. So that is what we want with reabsorption, is we want to give it back. Because remember, this was a passive process of filtration. It just went through the slits, all depending upon size. Glucose, we want that back. Sometimes we need to have some of those ions back. Like, we maybe necessarily didn't need to lose all of that sodium. So, like, I need that back in order to work my sodium-potassium pumps. So anything we want back, we're going to reabsorb that back into the peritubular capillary bed. Now, some things weren't small enough to fit through the slits.
So now what?
So now, if we still have things inside of our blood that we do not want there, that's whenever we secrete it and we get rid of it.
Spit it out.
So it leaves the peritubular capillary beds and arrows into the tubes. So you see the arrows that are flowing into the tube?
Absolutely. Under the bottom there.
Okay, so anything that goes into the tube, that is the process of secretion. Reabsorption, give it back to me because I need it.
You talking about the black ones? What arrows?
No.
Let's be more specific.
Let's look at like this little orange one. Do you see this little orange one right here?
Gotcha.
Going into the tube, going into the tube.
Gotcha.
Okay, I don't know if you guys can see my arrow on my picture or not, but if not, just use your little key and it'll show you down here where's water reabsorption, where's variable water reabsorption, where do you have solute reabsorption or secretion. Just follow the arrow. If it's leaving out of the tube,
excuse me,
it's going back into the blood.
Got it.
Okay? You're doing so good.
I'm back.
So proud of you. All right.
It's so cold.
So, that being said, the process of reabsorption and secretion is ultimately going to give us urine. So we can't call this urine all the way along, right, because it hasn't been messed with enough.
And some of it is going back.
And 99% of it is going back.
You said 1%. It's always the funky 1%. See what I did there?
Yeah.
Funky 1%. It's called pee-pee.
If we were actually getting rid of all of the stuff that we actually filtered out, we would dehydrate in a matter of hours and die.
Dead.
Yeah, no mas. So the collecting system is actually the last spot where any adjustments can be made in regards to any selective reabsorption or secretion. Whenever you look at the, one thing I forgot to mention, the DCT, because of secretion.
The distal.
The distal convoluted tubule is where a lot of the secretion will occur. So the secretion of things like drugs, if the things were too big to fit
what kind of drugs?
through the slit.
What kind of drugs are we talking about here?
They could be prescription drugs. They can be any kind of drugs.
Gotta watch her.
Just drugs. All right, so they will come out of the blood supply, get into the DCT.
I call them vitamins. It's different.
Oh my goodness. Okay, so that's how that works. Collecting system, last ditch effort to really kind of make sure that everything is exactly where it needs to be. In the collecting system, you'll also find the opportunity for ADH to go to work. So remember, ADH is your anti-diuretic hormone. Anti-diuretic hormone means that it is anti-diuresis. What's anti-diuresis?
It doesn't do anything for diarrhea. It doesn't dehydrate you. It helps you retain water.
Exactly. It doesn't dehydrate you. It helps you retain water. So if...
She didn't know I was this smart. I'm just going to tell y'all that.
So if you get aquaporin channels, again, to be talked about more in lecture, the aquaporin channels allow ADH to work like they're supposed to.
Does my smart make me sexy?
Yeah, it does.
Okay, I was just checking.
For sure. All right. Love it. All right. So that's how it all works. Okay? We filtrate. We do that in the renal corpuscle through the glomerulus.
Right.
We reabsorb. That means we take back what?
The stuff we need.
Stuff we need.
Sodium,
glucose, all that good jazz, water.
Ions. We need that.
For sure.
It was like, just kidding. Give me that.
And what is secretion?
Oh, that's the stuff we don't need. That's 99% of it.
No.
The 1%.
Yes, that's part of the 1%.
Pee-pee.
The 1% is going to ultimately end up as urine. Okay?
Why she got to be so technical? Urine.
So, if you look at the slide here, you can see the PCT and the DCT underneath the microscope. The black is actually pointing to the glomerulus, like we saw earlier, actually specifically the Bowman's capsule. And then the little model below that, you can see some of the PCT and the DCT of the nephron. So just make sure that anytime you're going to label the PCT, you just make sure it's closest to that glomerulus. And then that long structure is going to be a part of your collecting system. So that will be the collecting duct. Remember, multiple nephrons can feed into that.
That's
all right.
Cool.
This is the sequence of events of how it all works. So we filter.
Screenshot that. You're going to need it.
We filter through the glomerulus. We end up with filtrate in the capsule. The filtrate leaves the capsule and goes into the PCT, now known as the tubular fluid. Oops, my bad.
You had one job.
One job. We go through the nephron loop, the descending limb, then the ascending limb. Talk more in lecture about how that really changes the concentration gradient so that we have concentrated urine so that we're not dehydrating ourselves. Then finally in the DCT, where a lot of the secretion is going to be done, then into the collecting duct where any final adjustments can be made. After the collecting duct, then it will go through the minor calyx, the major calyx, the renal pelvis, all of those structures we talked about in the very beginning, into the ureter, which is the connection between the kidney and the bladder. It'll be stored in the bladder until it's time to be eliminated through the urethra.
I see you pee.
Very good. That was good, babe. All right, so last few things to talk about. We have the ureters. We've already said that they are going to be the things that actually transport the urine from the kidney to the bladder. They're covered in transitional epithelial tissue, just as the bladder is. The urethra also has some transitional epithelial tissue. What?
She always get a joke. You better not be in that toilet! Let's talk about pee. Just my bad. I'm sorry.
Okay.
My ADD. I'm back. I'm
glad you're back.
Whew. Now, what were we talking about? Start over.
Ureters.
Okay, ureters.
Little
transport
tubes.
the urine. Yes.
Yes. Go down to the bladder.
Yes.
Okay. Bladder is where we collect it and hold it temporarily. You really shouldn't hold your pee in. Like, you know how some people are like, oh, I don't like to get up and go pee, you know, if I'm watching a movie or something.
Well, I was at work one time and I had a bad experience with holding my pee, so I'll never hold my pee again, ever.
Okay, don't tell us.
Well, I mean, I held my pee, and then when I actually went to go pee, it was like, because, you know, that I guess, muscle on, I don't know. But blood came out first, and I was like, nope, never holding my pee again.
Oh, yeah, that's not good.
Yeah,
okay,
exactly.
So he has some other stuff that's not always something that's actually going to occur in everybody. But that's why he's sitting with me on the urinary system, because he's going to tell his story. that's related to the urinary system.
got
If you
it.
ever have blood come out of your urinary tract or your digestive tract, you should definitely get that checked out, okay?
That's why she likes me. I'm a personal guinea pig.
Exactly.
Can somebody come save me?
All right, into the bladder. Don't hold it. You do have that internal sphincter, which is involuntary. If you are holding it for too long, that involuntary sphincter will release, and that is what can cause you to pee on yourself.
Drippage.
Yes.
Got the little drippage. Didn't make it.
The one that you do control is the external sphincter, so that is a skeletal muscle that you can squeeze together. I just put a little note for you right there, S234. Whenever I was going through school, we always remembered S234 keeps the pee and poo off the floor. If you ever have a patient who does not have the ability to retain,
You nasty.
it's a serious deal though. Like if you're in certain areas of medicine and you have a patient who doesn't have the ability to hold in their pee or their poop, then there is some spinal cord damage somewhere. So you would want to go look in that area where S234 would be coming from, because they don't have the ability to control anymore. So that's a very bad diagnosis.
Won't be working in that section of the hospital.
All right.
I can't say that, but I was finna say it. Y'all know what I was finna say. I got other to do.
The urethra. We, again, already talked about that, how it gets out of the body. Remember, 4 centimeters in a female, 20 centimeters inside of a male.
25. Nobody's counting though.
That's the reason why the females are more likely to get a urinary tract infection, because their urethra is so short, whereas males is longer. So the urethra being short means that bacteria have a lot less distance to travel in order to get up into the urinary system and create that infection. Additionally, the urethra in a female is so close to her anal sphincter, or not the sphincter, but to the anus. So any bacteria that's in that area can easily travel over into the urethra. So that's why we always wipe front to back as females. Remember what I taught you whenever we had CC, you front to back.
Y'all nasty.
It's just a part of life, baby. It's just physiology.
No.
So
Front to back.
keep everything clean. Make sure that that bacteria doesn't have the ability to go into the urethra and then cause those infections. If you are consistently getting those infections, you could get frequent medications which don't always help things, like the antibiotics and the antifungals. I've spoken to plenty of patients who have been put on countless numbers of those, and they just keep getting them. It's like these repetitive cycles, because it really messes up their flora. So there are other things to do in order to make sure that you maintain all of that, but hygiene has to be one of those things.
I got a power wash. I can wash it out.
Next slide.
Anyway.
All right. So here is some pictures of the ureters, including what it looks like underneath a microscope. You can see all of the different 3 layers that we have inside of the ureters. In regards to the bladder, there's a couple of different ligaments that you want to make sure that you can label, make sure that you can see the detrusor muscle. Again, more information on that in regards to how that will help control micturition. What's micturition?
Oh, yeah, we did that on the first slide. Go back to the first slide. Look it up.
Urination. Okay?
Just means pee.
The trigone, if you look at this little picture right here, what you can see is there's a little triangular space. So this trigone is going to be a triangular area that includes the 2 openings to the ureters and then the entrance to the urethra. So it just kind of creates a little triangle that acts like a little funnel that helps channel that urine into the urethra when the bladder contracts, because you do, whenever you pee, want to completely eliminate. You don't want to have you don't want to have pee sitting in your bladder as just residual. You want to constantly be moving it all through. There could be increased risk of infection if you can't properly void.
So is that why they say when you sit down and pee, you should probably hike your legs up, so you gotta put a little pressure on your bladder.
I've actually never heard that before, so.
You should probably read it.
Okay.
I'm smarter than the doctor.
I'll look that
Hey,
up.
the other question I have for you is, which one of these parts here sends the signal to the brain of, hey, you need to pee?
Okay, so that has to do with all of the nerves.
Okay, never mind then. We're not there yet.
Okay, but that's a lecture question.
Oh, no, I'm not going to that class.
Okay.
Never. Oh,
All right, that is coming on the
you
lecture.
want to talk about my prostate? You want to talk about prostate?
So if you do have males who have problems with peeing, if they do not have the ability to completely void, or there's dribbling or things of that nature, if their prostate has enlarged, it can actually squeeze that urethra, which would mean they don't have the ability to use the restroom as they should. That is definitely a painful thing for some of them, so you really do have to be very good with your bedside manner whenever you talk to these patients, so they do feel comfortable opening up and speaking to you about any issues that they may be having. So BPH is benign prostatic hypertrophy. That's just what I'm talking about here, as that prostate gets a little bit larger. There could be a number of different causes for that. You always want to take care of the male's prostate. We have talked...
That's where I come in. So all my healthy males, you make sure you eat your tomatoes. Because on the flip side of that, if you ever have to get that prostate taken out, your little man part, I'm not going to be a victim. Eat your tomatoes.
So it is possible that if you do have to get your prostate removed because of something like prostate cancer, then it is possible for you to lose some of your length, some of your penile length. So that is what he was referring to. He actually met somebody who had this discussion with him a few weeks after I told him to eat his tomatoes, and he refused to eat his tomatoes. But then...
I eat tomatoes on everything now. Tomato juice, tomato salad, tomato paste, diced tomatoes, you name it.
So take care of your prostate. Tomatoes...
Catching up for all them years I lost.
Tomatoes have lycopene in them, which is really healthy for your prostate. So if you need more information on prostate, we'll let them look that up so we can move on.
Okay. Cool.
All right. The bladder wall, again, that detrusor muscle is going to be inside of the bladder. That's going to help you with the elimination of your urine. And there it is. You can see it underneath the microscope. So why does all of this matter?
Because I got to pee. It's simple as that. I got to pee.
3 functions of the urinary system. We have excretion.
Nephrons.
So the nephrons are the little functional units that are going to be doing the filtration, the reabsorption, and the secretion, so that ultimately we can excrete out urine. Clean the blood, because the blood is bougie. Clean the blood. Okay. Elimination through the urethra, get it out of the body.
What up, blood?
In order to maintain homeostasis. So we want to maintain homeostasis because the volume and the solute concentration is so incredibly important. We don't want to mess with volume. If we mess with volume, we mess with pressure. So when I say we don't want to mess with volume, what I mean is we don't want it to be too high or too low. Okay, we want good balance. Again, same thing with the solute concentration. We want to make sure that all of our solutes are exactly where they're supposed to be so that everything can work in the body exactly as it's supposed to. Now, you'll see on this slide right here, we've got a couple of different things where you can read through about the volume, the pressure, ion concentrations, blood pH, all of the things that the urinary system is really going to make sure that it is doing for you. So you didn't even know that all of this was going on every time you went to go pee. You may not have even known that it was your blood that was being cleansed is what gave you your urine, nor do you maybe know that the kidney and the liver are very good friends. They're like BFFs. So the kidney will assist the liver.
Out of East Texas, we call them cousins.
Okay. Kidney will assist the liver in detoxification. So liver is a filter to the body, and it filters everything that comes in. So if you are, going through a lot of medications, maybe you're on a particular regimen of things for a particular medical condition, then the liver is going to have to filter and process all of those things, and a lot of that stuff is going to end up in the blood, which is then going to have to be cleansed out through the kidney. So these two work hand in hand together. Very important to make sure that they're always happy and that you're always doing whatever you can to support these organs as they're trying to keep everything inside of your system clean and functioning well. So let's get real. Do you really have to pee?
No, but I'm kind of thirsty. Thanks.
You're welcome.
She's sharing now, guys. Look at that.
So tell us your story. Tell us, besides the fact that you had to stand in as a student today in order to kind of break down this whole entire thing, you know what we forgot to do? We forgot to draw.
What was I drawing?
We were going to draw the nephron, but it's all right. We'll draw it another day.
Yeah, when they start sending in their jingles and dances, we'll send out drawings.
Okay.
All right.
All right, so tell us your story about your urinary system.
What week are y'all in school? Y'all ain't in school, y'all at home. So where do I start? First, I guess let's start with, I don't know why this happened to me. I know that sounds weird, but I don't. Back in 07, I guess that was almost a little bit before. No, that was after we met. Girl, when we meet.
Oh, sorry.
So that was...
Yeah, it was a few years before when it all started.
First episodes before when all this mess started. I have a condition called rhabdomyolysis. At that time, I didn't even know words that big. Didn't even know people who knew words that big. So didn't know what was going on. Basically, I woke up one day, I was sore, stiff. She was talking about the filtration of the blood. Anybody knows that works out. You get all that
acid buildup.
Yeah, acid buildup in your muscles from working out, and I wasn't working out, so I couldn't figure out why I was sore. And I was at work, still going to work. Not a high-stressed environment, so I didn't have any of that going on. And I went to pee. I-C-U-P. Went to pee one day, and my pee was literally purple. I wish I could say what I wanted to say, but it's a classroom environment. Scared the living daylights out of me. Let's keep it PG. Scared the living daylights out of me. I go to my doctor. The doctor put me in a personal car and rushed me to the ER. They got me in there, ran all kinds of tests, and so this is why I'm counting on y'all to learn this stuff, because I got about 8 diagnoses before I got the right one. That being said, they diagnosed me with rhabdo, and I guess the crazy part is it's normally found in tennis players, which never played tennis a day in my life. It was for extreme dehydration. I worked in the air condition. It just didn't make sense. So
they didn't know a lot about it at the time.
Yeah,
there wasn't a lot of people who had information, so that's what they said it could be.
Right.
Tennis, dehydration.
They tried to call me a crackhead, said I was on drugs.
It could be drugs.
I took dare every year in elementary. I say no to drugs. Okay.
Tox screens came back clean.
Yeah.
They said it could be marathon runners, which you don't run marathons.
I ain't running nowhere to the table. Pass me a fork and a spoon.
Yeah.
Anyway, that being said, they just didn't know.
And no history of family
right,
stuff.
And it's not
so
in my family.
Nothing.
So that was literally
no clue.
I was that patient that you see on House and on The Good Doctor. That's her show, The Good Doctor. So anyway, that being said, very odd. And it's kind of, the emotional side is kind of depressing when you have something and, you don't know how you got it. It's kind of like, the pandemic that's going on right now with the corona, but we won't go in that because I'm tired of hearing about that. That being said, I met this lovely young lady here and didn't really have any episodes going on, and I didn't really tell her. I was kind of embarrassed about it. Right until I had an episode, and
But you had multiple before you met me, right?
Right, I was having one every year, literally like clockwork. It was like every year, like clockwork, and it was weird because I knew it when it was happening, and I just go to the ER. They admit me.
Tell them about your legs.
Oh yeah. Like my legs, they would, like I said, with the workout, the feeling like how you did a good leg workout. Ooh, I'm sore. Now imagine that times 10. Like I could barely walk. Like when I say I understand what it feels like to be paralyzed from the waist down. From the waist down. No action. From the waist down. Anyway, that being said, to the point that I let it get so bad the first time, because in the East Texas, in the country, we don't go to doctors. We self-diagnose. Anyway, and I got so bad the first time till I was literally walking on my tippy toes because my muscles were literally drawing up that tight. So that was probably the longest stint I was in the hospital for the first time. I was in there for the 8 days on fluids. I had an IV in both arms. So, and basically they told me if I had waited any longer, we might not be having this little meeting here, teaching ceremony, whatever this is. So that being said, I guess, and to give you kind of a glimpse into how bad it is or was, when you talk CK values.
I'll tell him about that in a minute.
Oh, excuse me. Don't want to steal her thunder. Anyway, she'll tell you about that part in a minute. But it's just kind of sad. But anyway, long story short, this is why I believe in, one of the reasons why I believe that God is a healer. Like I said, I bumped into this lady here, and, I've been a Christian all my life, and, she was pregnant, and I couldn't imagine what she was going through, just knowing that there's a possibility that her baby daddy could die on this bed. Or, not necessarily die, but be a victim of dialysis at the age of 27, 8, and have to go through that every day.
Yeah, because what they said whenever he had his episode shortly after we met, that was the first experience that I had with it. Because like he said, he didn't tell me about it, so it was
and that
me.
was like time number 4.
Like
3
5.
Was that 5?
Yeah.
That was like time number 4 or 5.
So with me showing up at the hospital, I had no idea what was going on, and I tried to talk to the nurse and get more information about it, but she really didn't have any information. The doctor really didn't have much information, and basically what they told me was, we don't know much about this. We don't know why he has it. There isn't anything that we can do for him other than give him IV fluids, and he's been in too many times within the past few years that if he has one more episode, he will need dialysis because his kidneys have worked too hard. Because basically what's happening is, as his skeletal muscles are breaking down, the myoglobin is coming out of the muscle, leaking into the bloodstream. And again, we just talked about the kidneys have to filter the blood. And the myoglobin was causing a lot of oxidation inside of the kidneys, and it was destroying a lot of the different structures that are integral for blood cleansing. And the myoglobin can also cause a release of other cascade events. So without getting too technical into it, they basically told me there isn't anything that we can do to help him. There isn't anything that we can do to be proactive about this. All we can do is just give him IV fluids if he shows up in the ER again, but just prepare for dialysis if he does come back. And based upon his history, he will be back. And that was basically what I got. They told us there was somebody in the Dallas area. There was one person who may be able to help, but whenever I called that person, they had obviously a horrendous waiting list, and I could not sit around and wait and just do nothing. So that's whenever as long as you know your physiology took over. I went and talked to my mentor, started getting more information about the kidneys, had to go back through a whole lot of things in regards to how the kidneys work, and we started him on some stuff.
Some vitamins.
Mm-hmm.
But that being said, the biggest thing that we started with was prayer.
Yeah.
And this lady laid her hands on me. I don't know if she's broke down all of her magnificent things that she does and can do, but she's crazy special, crazy intelligent. Like I'm a lucky guy. I really am. But that being said, she laid her hands on me, and we went to the Master, the healer of all healers, and we asked him to deliver me from that thing. I don't even know what to call it, just a thing. And from that moment in 2007, I've never had another episode until Crash Dummy here got started being crazy again. But until what, 2012?
2012. So in 2012,
look at my baby.
You decided to do this.
So let's talk about this first. I've been riding motorcycles since I was 13, 14. Like, I've been doing this for a while. I can't make other people learn how to drive. This doesn't work. Yes, you do have to drive everybody around you, but look at my baby. And so this is around the time, and you got, she knows, but, the stupid guy that you see riding down the street at 100 miles an hour on one wheel and all that kind of stuff, I did all that, and lived to tell about it. I had finally entered the stage of, you know what? I got a family now. I got some kids. I got to stop being cray-cray. But I still like the sport bike, so I tell you what. I'll make a deal with you, babe. She said what? I'm going to get this bike, and I'm going to fix it up. And I'm going to fix it up so pretty that I ain't going to want to do nothing stupid on it. And as y'all can see, all this paint, all these stains, like I could really go through the details. That's all flames on the wheels and flames across the bike. Next picture, see like this thing on the windscreen here with the skull and the angel wings. I drew that, and I know y'all can't see it on that picture, but it's got all the kids' name and Stephanie's name, and I got 3 skulls here in the mirror, and one for the Father, one for the Son, one for the Holy Spirit, and then like the flames, all that kind of stuff. So all of this is like personal design type stuff. And next screen. Yeah, and I don't know why I was fascinated with skulls. I think it just comes with the territory. Not that I'm that evil, gothic, whatever dude. It just comes with the territory. But it was pretty. And it was the same color as my truck. And then, you see this ish here? You see this?
A few hours after you got finished.
No, this is the day after, actually, because I put it together. I finished putting it together the day before. And I put insurance on it that day. And
so a few hours after you got insurance.
A few hours after I got insurance on it, I was like, hey, babe, I got a cousin in town. I'm going to go down south and see him. Because he was at a famous eating restaurant down there. I don't know if it's still down there. It's still down there?
I don't know.
Anyway, go see him. I go see him, talk to him, come back. On my way back, got my little ear pods in my ear, and I'm jamming and I'm riding. I'm in the HOV lane, where motorcycles are supposed to be. Driving the speed limit. Why the little lady want to cut me off? I have no idea.
In the area where you're not supposed to go into the HOV lane.
Okay, let's not tell that part because we don't want your blood pressure to get up this evening.
Okay?
Just stay right here. Let me tell the story.
Okay.
She crossed the double white lines, okay? I hit the back of her car going about 70. 75. Okay, 80-ish. Either way. Boy, I tell you what, we talking about the renal, not the renal.
Adrenaline.
No, not adrenaline. I'm talking about when my nuts kiss the gas tank.
Oh my God.
My testes hit the gas tank so hard. Anyway, keep going.
Because you rammed her.
Yeah.
And the whole indention of your front of your bike was in her bumper.
Right.
Flew over her car.
Yeah, flew over the car. And if that wasn't enough, then the heifer ran me over. So don't make no jokes about being ran over by the bus around me. I lied to punch you. Because it wasn't a bus. It was like a Honda something. Hyundai. Not even a Honda. Hyundai. Anyway, that being said, she ran me over. I tell you, there's no such thing as luck. So, don't believe it. It's all blessings. I promise you that. So, she ran me over. And I was literally trying to get up off the ground to make sure this lady stopped. After she ran me over. So, my bike hit the center pole that holds the sign that says Parker. That's what kept it from flying into the other lane. That's how hard I hit her. To give you it airborne the bike. I've seen a lot of bike crashes. I've been in a few. I've never seen a bike frame break in two. Snapped this in two like it was a stick. So, and I still have this bike, by the way. I went to go see it Friday, on Good Friday.
This is at my father-in-law's house in East Texas because it is not coming back to ours.
So,
ever.
That's what I'm going to tell you about, but we'll talk about that later. Okay, thanks?
Mm-hmm.
Nah, I'm just kidding. I just got to move it off. I'll move it out the way, and I will put it in the woods. It's fine. Anyway, so that was that, but
So you got up and you tried to chase her.
I did. And the guy.
And that's when you realized.
The guy was like, hey, get down. Just lay down. And I'm like, no, that choice word, stop. Because, you know, at that time, people were hitting motorcycles and, you know, acting like they didn't know they hit something and kept driving. But he was finally like, look at your foot. I looked down at my foot and I was like, yeah, I'm going to go ahead and lay down. So, anyway, it's called a dislocation. What is it? Dislocation break open contusion. That's what it was. So basically, my foot, because of the way, you know, you ride motorcycle, was under the gear. So when I flew off, it snapped it. And when it snapped it, it went all the way under and popped the bone that way. That's why it dislocated and I broke my tibia. We'll get to those pictures in a minute.
I think that's actually what's next.
No,
there it is.
There you go. That's what it looked like on x-ray, but that's after they had rolled my foot back around the right way.
Yeah. After it was facing back
shout
forward.
out to Plano Fire Department. You know, they fixed me up. Gave me some terrible drugs in the ambulance though, because I didn't feel no pain until I got in that ambulance. I'm like, what is this? They didn't know I was allergic, or I say allergic. I don't know what it is. I'm not allergic to morphine, but it just don't do me good. Don't do me good at all. It sets my body on fire. So at that point, I could feel everything. But that was a fun break. I actually broke that same bone at the top, a little bit below my knee area as well.
So the fibula was broken 2 places, and obviously the worst area was down near the ankle. So whenever I got to the ER, obviously there was blood everywhere, and I was freaking out. And you can see this
She said
picture.
that real calm and nicely. She over here shaking now, like y'all can't see it, but I can feel her shaking, like she's shaking.
You can see
it's
this
over.
Picture where you can see the tire tracks on his leg as the lady ran him over, and then the second picture is his ankle. The surgeon came out and told me in the waiting room that because the contusion was open about this big, he said he was going to try to get the skin to come together as best he could, but he wasn't sure. He may have to do a skin graft, and so I had to sign off for a skin graft, and the surgeon was able to do the surgery without the skin graft.
Calm down. Calm down. It's okay. I'm still here.
So, then you call that your sushi, babe?
Yeah, that's my sushi.
So it's left open because he obviously had to watch it. So he couldn't cast it right away because he had to make sure that it did not get infected, because there was such a large area that he had to close up. And
the longest 8 months of my life, I promise.
So that is what happened in that particular situation. And
so I was there for 4 days, and they was like, all right, well, we done patched you up. You can go home to the house now. And I'm like, oh, yeah? I was like, okay, cool. Called my old lady. Hey, they let me go home. She's like, what? I'm like, yeah. She come get me. Old rhabdo shows up again 4 days later, and I got to go back to the daggum ER. Because we didn't know at the time. Trauma.
Crush injuries. That's one of the things that was never said, but later on we found out that crush injuries do spur rhabdo events. And because he had experienced a massive crush injury between getting run over and, of course, getting his complete ankle just completely twisted around, all of the muscles in the area had been through severe and extensive damage. So he did end up having to go back into the hospital.
Hey, you should put like all my videos up of like, you know, the doc doing stuff that they said I wouldn't be able to do anymore. You should put them up.
Okay.
So they'll see
Okay.
that God is real.
We'll get to that.
Okay.
Okay. So this picture that you see here, basically what you see on the
purple pea.
left-hand side, the coloring is not that good, but yes, in real life that pea is purple. And he spent a very long time in the hospital for this bout of rhabdo. what you see in the back,
That's me laying there.
that's you laying there.
Wow.
What you see in the back that is circled in the black are the little vitamins. So he had been off of his vitamins for years, because once we got him established and he was healthy and he was well with his kidneys, from his 07 admission into the hospital, he was not continuing on his regular vitamin schedule because his kidneys were back and normal and good. And like he said, we had prayed over it and he hadn't had another episode. So we discontinued the vitamins. Whenever he was laying in the hospital, he spent a long time in there, and I was basically running the house, taking care of the kids, became the primary breadwinner because he obviously couldn't work. And so I had forgotten to take care of his kidneys. And whenever I found out that his CK levels were getting worse by the day, I eventually got a hold of the lab report and saw that his CK levels were above 100,000. And that is way high. So you can see that I put on the screen right there, 22 to 198. It really depends upon the lab that's pulling on. Some labs will go as high as 300, but about 200 would be the max. Anytime that muscle tissue is damaged, they will pull CK values just to check and see, is there showing up in the blood the creatine kinase. The creatine kinase is the indication that there is muscle damage. So for his to be over 100,000,
I'm special.
You are special, and I love you so much. I
just
freaked
get on
out.
my nerve, really. That's all. I'm always doing something. She like my mom. You know your mama tell you, you're always doing something. Sit your ass down.
True. I freaked out at the CK values that were getting worse by the day. And I immediately went to go and get him vitamins. Whenever this whole thing happened in 07, basically when I sat down with my mentor and I had him guide me through the urinary system, so even though we couldn't understand truly what rhabdo did, as long as you can understand the true physiology, then you can work out things that are occurring in pathology. And that's what my mentor and I did back in 07. So I went and got him these vitamins that you see circled there. That P that is purple on the left-hand side was before he took the vitamins. It took me about an hour to go and get the vitamins. Once I came back, then I told him to take some, and I gave him 1 hour after he took it, told him to pee again, and that is the P that you see 1 hour after taking those vitamins to support his kidneys. So the next day, did you get out the next day?
So, mind you, this is the part she's not telling. Because now she a drug dealer. We had to sneak and take these because the hospital would not let us take our own stupid vitamins.
So, you know,
Drug dealer.
at the end of the day, I'll do anything for you, babe. 'Cause I love you.
Bonnie and Clyde, ride or die.
Yeah, for sure. So, at the end of the day, he was able to get out of the hospital.
It wasn't
I
the next
did
day,
have
though. It
them.
was like, they kept me for like another 2 days.
They kept you for another 2 days?
Yeah, like another
Okay.
2 days.
I did have them check into his kidneys because of that 07, hey, if this happens one more time, you're going to need dialysis. So whenever they looked into the kidney structure and function, they were able to tell that he did not need dialysis. So even though this had occurred, they said that his imaging looked so great that it looked like he had never even had a rhabdo episode before in the past. So that was one of those praise God, hallelujah moments because his kidneys had been completely healed.
Super doctor.
Oh, you're so sweet. It wasn't me, it was Jesus. So that being said, if you know what you're dealing with, this is why I tell you guys to know your physiology, because if you know your physiology and you understand the general basis behind it, there's going to be times where that's going to be the thing that's going to help you kind of get through what it is that you need to get past. If you don't know the physiology, then you really don't know what to do to support your physiology. So that's why it's so incredibly important to learn these things. The other thing too is whenever you're in the hospital as the nurse, I know not everybody's going to be a nurse, but whenever you're in the hospital as a nurse, he tells his nurses, hey, I have rhabdo, just so that you know, because really the only thing that they can do for rhabdo is massive IV flush, and that's it. There's no medications or anything like that they can do. All they do is try to get all of the toxins out of the kidneys and just flush with IV fluid. So since 2007, there have been more information that has come out about rhabdo since then. Now you can actually find things on Google, whereas in 2007 there wasn't even anything on Google. Now there's more information out there, but they're still doing the exact same treatment.
Hey, pause. Let me in here. Dog, you talk so fast. Another thing to you, gonna be nurses, all that kind of stuff. Make sure you listen to the patient.
That's where I was going.
And
you go there.
I'm going. And do not fall into the norms of, well, we did this the last time for the last patient. Because every patient is different. Dagnabbit. Okay? I'm different. I know I'm different. So I be trying to help them nurses. They don't be listening. And when they give me the wrong stuff and it don't work, they're just wasting my money and their time. Okay? So just listen. You can finish. You can do it professionally now. Go.
So there's a thin line for that. Obviously, there are some patients who are just going to talk and have no idea what they're talking about. But if you do hear patients talking and they're using anatomical terms and they are using actual textbook diagnoses that you have actually studied, or if you haven't, if you've never heard of something, then just make sure and make a little mental note and say, let me go look that up really quickly so that way I can best serve this patient. There are nurses that we think have been great because of their ability to listen and connect. Their bedside manner was phenomenal. You could tell that they really did care. And then you could also see those nurses who really just went based upon, well, I don't know how to deviate outside of anything that I normally do, so anything new that's thrown my way, I don't really know what to do with that. It was very evident of the difference between somebody who has the capacity to listen and to learn and who wants to help versus somebody who's just there to just, whenever my 12-hour shift is over, I'm out. It's very evident.
Right. There's a difference between a career and a job. You know, people who with a career love what they do. People with a job are just waiting on a paycheck. So just keep that in mind.
Yeah. And then also in regards to the same visit time frame, his hand right here, this is for those of you who aren't going into nursing, but you're going into imaging. Whenever he had that motorcycle accident, because everybody was so concerned with his foot, as you can see his foot is now casted because it's been some time, he kept constantly complaining about his hand.
That's a soft cast. They used to unwrap that and check it and then wrap it back up.
So that being said, if he was constantly complaining about his hand and it took him a long time to get somebody to actually take him what's the word I'm looking for? Seriously.
Right.
Now we're
Somebody
delaying
to
treatment.
listen.
We're delaying treatment at this point. So everybody kept saying, well, yes, sir, your hand is going to hurt because you have road rash. And he kept saying, no, that's not what it is. That's not the kind of hurt that I'm talking about.
And on this particular hand, I actually had stitches across the top because I had a watch on, and the watch had cut me so deep in that scar that they had to stitch it back together. That's the one I was sitting there, and I pulled the stitches out. And you
yes, yes, I know. So he took his own stitches out.
Yep. I'm the doctor too.
You're great. So he told the nurses, and it took a while for someone to actually say, okay, well, we'll go ahead and get you into radiology to see if anything is broken in the hand. And how many times did you go to radiology, baby? Three? Three times in radiology. Did you have 3 different technicians?
Mm-hmm.
3 different technicians. So if you're going to be a technician, this is where you need to understand the importance of what you do on a daily basis and how you set up your exam or your x-ray is going to completely depend upon what kind of image you are going to get. So 3 different technicians, I'm sure because it was 3 different days with 3 different technicians, it was probably 3 different radiologists who read the x-rays, but all of the reports came back as negative, there's nothing wrong. And then about 6 months after he had been out of the hospital, he still complained about his hand, and I said, okay, so babe, tell me exactly what it is that's bothering you. Like, give me more description so that way I can figure out how to best help you. And that's whenever he told me that the range of motion wasn't what it used to be. So I decided that the best thing to do would be to take him to where I went to school. We went up to Parker so that way he could get x-rays by one of the docs that I knew. And he was so amazed whenever he came out of there and he said, they had me do this move that I never did in the hospital, right? You remember that? And so I knew it right then. It was all about positioning. And by that change in how they manipulated his hand, they were able to see that his scaphoid had broken in half. But at this point, because it had been so many months after the break, the scaphoid that was not receiving any blood, the piece that was no longer connected, was now necrotic. And it was no point in doing anything because the bone was dying. And he would never have normal motion in his hand again, which meant he can't do normal push-ups, which means that that changed some of the physical agility tests that he had to go through some of the cities because he wanted to be a firefighter, and some cities would not accept him doing push-ups like this because they wanted push-ups like this. But because he could not move his hand in this way, it was an automatic no, which means the technicians, had they have found it then, may have been an opportunity for that to have undergone something differently so that way he could restore range of motion in his hand and not changed multiple aspects of his life, not just the range of motion. So as technicians, what you do is incredibly important as well. Make sure you study your craft and you know how to manipulate so that you can get the best image possible based upon what's going on with that particular patient, because everything isn't always going to be written down in a book. Sometimes, again, you have to think outside of the box and you have to learn how to really, truly listen.
Yeah, so to what she's saying, thinking outside the box, then I couldn't put it into words or what they made me do, but after they figured out what I was doing when I actually broke it at this point, they basically made me put my hand in that position and like rotate it over because I was riding a motorcycle, and anybody that rides a bike, it's the same motion. So when they did that and they just kind of elevated it on that block so they could, whatever the little block thing was, that's how they captured that image. So.
Thanks for that.
Yep.
All right, so.
Well, now.
Last story, and then we're done.
Still talking about me, huh?
Okay.
Don't get in a hurry. That's what this means. Nothing to do with urinary tract. Just want to tell y'all that, as far as it, when, like I said, I don't want to preach to anybody, but, as they say in the political world, if you don't believe in a higher power, this is like literally like a week or two, 2 years out from my quote-unquote anniversary, if you want to call it that, from when I had the motorcycle wreck. This is 2 years after. This is the truck, same matching color. This is the reason I can't own another red truck, because this is red truck number 2 at the time. I didn't wreck another red truck since then, but that's not. She said I can't drive, but the truth of the matter is I drive really well. Well, don't worry about that. Anyway, but if you'll notice here, the only part of this windshield that's intact is the piece I'm supposed to look out of. If I go to the next slide, I believe. Yeah, that's the side piece. I was in this vehicle headed to referee a basketball game, and some things happened on the highway there, and trying to miss a car. I don't know if she's told y'all, but I'm into race cars and things that go fast. You didn't tell them that? Yes, more race cars to come. Anyway, that being said, I had done some work to the motor in this car, so it was a little bit faster and a little bit more torquey than it was originally. But got off on the shoulder with the back tires of a rear-wheel drive truck, and then trying to get back into the street, I overcorrected and it rolled 7 times. I'm crazy about numbers. She thinks I'm weird, but 7 is always the number of completion. And because of this truck right here, I'll forever own a Dodge, whether it works or whether it don't work. I'll forever have a Dodge in my driveway. I rolled this truck, it flipped 7 times and landed wheels down, and I drove it another 150, 200 yards. And I was on my way to referee a basketball game. There's the other pieces there. And literally you can see the only glass that's intact, like I said, is that windshield in my window. And I tell her that's, you know.
The next picture. You can see your
there
door.
You go.
So now you can see that.
Yeah. You can see the top is all crushed. And I just, you know, I always say that, you know, my wife likes to say an angel was looking out for me. My mom died when I was 17. But God's hand was on that vehicle as it was tumbling and rolling. Let me just say it that way. And I was literally 10 minutes late for this basketball game and refereed the whole game. So I tell you, God is real. I really do. And so you should count it all joy in everything that you do. You should definitely take pride in what you do, because as you can see, I'm an accident waiting to happen. Let her tell it. And I'm counting on y'all guys to know your stuff. Okay? Literally. Like, because
you need good nurses.
I'm building a race car right now.
Good physical therapists.
Don't be trying to cut me off. I'm building a race car right now.
Good medical providers.
I'm building a race car right now.
Good technicians.
I'm building a race car right now. Are you done yet?
Mm-hmm.
I'm building a race car right now. And trying to be, you know, faster than, you know, twin turbo, you know, nothing major. For all you. So, like I said, count your blessings. Be the best you can be. Simply because, like I said, yes, I'm accident prone, but, you know, I have a heart for kids. You know, kids are innocent. Old people are innocent. I love my old people. Geriatrics patients. But they're innocent. And so, like she said, bedside manners and things of that nature is what make your job, I guess the word, I lost the word, whatever, but it makes your job worth going to. You can't be paid for that part of what you do, you know. So, yes, the technical stuff, you know, drawing blood, you know, sticking people with needles and all that kind of stuff. Yeah, whatever, you know. But
it's important, but who you are is also just as important. And
what you stand for, because, like I said, we both know, we've seen it. You get into the mundane of not necessarily a hospital, but any office, and there's an environment there. So you have to be courageous enough to, you know, be willing to go against the grain, or even recognize that, hey, you know what, this doesn't fit my personality or what I believe in, my morals, my values, so I'll go find a job somewhere else. Just remember, I tell, you know, my wife this all the time. When I found that job, I was looking for a job. So it's easier to find a job when you got a job. So don't let the fact that you make XYZ be the last say-so, because it's more to it than that check you receive on that Friday.
You never know whose life you're going to change forever.
At all. So the part she didn't tell is that lady that crossed in front of me, she didn't have no insurance, so it was all on us. And I saved that for the end because we're about to sign off. So anyway, thank y'all for letting me be a part of y'all's class. I hope you thoroughly enjoyed it. I normally come to the class on this meeting, but because of the pandemic and things of that nature, we got to do it this way. So I'm looking forward to some of the videos, if y'all take me up on that. The jingle, what's it called? What loop was it?
The dance?
Yeah.
Nephron loop dance?
The Nephron loop dance. Let me see something creative. I'm a creative guy. I'm a right-brained, she's not. So I get fascinated with stuff like this. And I'll make her give y'all grades, I promise. If you just try. We'll figure out something. I promise I will. You'll see it on there.
Extra credit.
Extra credit. That's what we have to call it. My bad. Can't be because if everybody don't do it, then, you know, we got problems in the dean's office. Extra credit. You're going to need them 2 points. I'm just a B student. I needed them 2 points. So, y'all take care. Love y'all. Do y'all's thing. Be great at whatever you do. And you got a great professor. I get to call her wife and honey and mom and baby and sweetie and all that stuff. But y'all call her doc. So.
Bye, guys.
I don't know how to get off of this screen. I'll get out of here.